Okay, good morning, everyone.
Good morning.
So as you know, I'm Marina Matute. I work for Baptist Hospital. I work actually in managed care and specifically in the Department of Clinical Documentation Improvement, where it's called CDI, Physicians. The whole department, we are physicians, international graduate physicians. What we do is to have, we check patients in the chart, patients, the electronic chart, every day on daily basis, in patients that are currently in the hospital, hospitalized. So we are under the umbrella of VP Finance Corporate. Okay, we are part of the corporate office. We're under the Vice President of Finances. Yes, the CDI physicians. I mean, we are part.
So that's Baptist Corporate.
That is Baptist Corporate. Yes. So it's called Clinical Documentation Improvement. So it's like a audit all the charts with patients that are in the hospital. Okay? So we're gonna start with our prayer here. So I bring the prayer of people of San Francisco, the thesis. So in the name of the Father, and the Son, and the Holy Spirit. Lord, make me an instrument of your peace. Where is hatred, let me bring love. Where is offense, let me bring pardon. Where there is discord, let me bring union. Where there is error, let me bring truth. Where there is doubt, let me bring faith. Where there is despair, let me bring hope. Where there is darkness, let me bring your light. Where there is sadness, let me bring joy. Oh, Master, let me not seek as much to be consoled as to console, to be understood as to understand, to be loved as to love. For it is in giving that one receives. It is in self-forgiving that one finds. It is in pardoning that one is pardoned. And it is dying that one is raised to eternal life. Amen. In the name of the Father, the Son, and the Holy Spirit. Precisely yesterday, I received in my email as an employee in Baptist, this kind of email, Compliance Matter. This is a compliance hotline. So they encourage the employees to speak up about any issues with ethical problems, conflicts that any employee can find in the area of services.
So they have to be ethical issues.
Yeah, well, ethical, any patient problems. I'm gonna put the examples here, and they say our values, people, compassion, excellence, integrity, and transparency, belief, stewardship, are the basis of our ethical standards. The Code of Ethics is a comprehensive guide to our application of those standards in our daily activities. So you're gonna read the whole thing, and they say where you have to click. If you have a concern that you believe violates our standards and you are not comfortable reporting your concern through the normal chain of command, or you do not believe your issue has been properly addressed, the compliance hotline is available to you. All reports are reviewed and followed up. Okay, so, and they say, retaliation for making a report is in good faith is not permitted. So you can be confident that you're not going to have consequences when you just call to say something. Some examples of reports include, you have concern about the codes reported on bills sent to insurance companies. You worry about the number of complex tests being provided by your department. Are they medically necessary? You have received notification of a government audit, but you don't know who at Baptist should be notified.
So this is to the patient now.
Yeah, you see that it covers all the issues, you know. The first one, you are concerned about the bills, exactly. So this is more with the billing issue, a HEMA that we call. All the department with the coders that they just send the bill to all the Medicare, Medicaid, and also. You worry about the number of complex, that's now the nurse or physicians or family, you know, looking at it's too many testing, too many tests or procedures applied to the patient. Or you receive a notification as a manager and you don't know who has to take care of this notification that the government is asking for. You have noticed that patients are often reporting to the emergency department the day after a specific procedure. This is complication of the procedure. You've seen that there are so many patients coming the day after. So what's going on with the procedure? I mean, something is happening inside of the department, the service, the procedure, infection, pain, something, and you are suspicious that something is wrong. Somebody's not doing his job properly. Or you know of a situation that violates our ethical standard, but you are afraid to report it to your supervisor because the suspicion sometimes is the supervisor or the manager is involved in this kind of stuff. So, and they recommend actions speak louder than words. I mean, you take action, call if you notice anything in your department that you think is not appropriate. Faced with a difficult decision, things to consider. Are my actions in compliance with our values, laws, regulations, and Baptist Health South Florida policies and procedures? That's the question you should ask yourself when you see something. I'm doing what they say we have to do. I'm doing what the code of ethics. Any new employee have to go for a general, what they call training, general information about the hospital, the culture of the hospital. And you receive a book, which it says the code of ethics inside Baptist Hospital. And they explain in that book everything about your behavior and relationship inside the hospital in different departments, you know. Are my actions in compliance with our value, law, regulation? What is the risk to our reputation? How would the public see it? What would my friends and family think? Sometimes when you by yourself, you say, well, what my family will say if this is happening? You know, so many patients with complications after procedures. I mean, so many patients coming several times to the emergency room and they don't take any actions. So I just received this yesterday in my emails to remind every employee, if you have any concern, you have to report it to this hotline and you're not gonna have any consequences. It's anonymous. If you don't want to say your name, you just complain and do the complaint.
A question I have, how can that be used to make mischief? And that can be used to create problems.
How? You mean the employee?
Yeah. I mean, employees can or one employee or several can have a resentment towards somebody and try to build something against them.
Yes, that happened many times. I
I'm
think,
sure.
Yeah. That's why they have the committed.
Vindication. This is what I want. They're looking for vindication.
Yes.
For something.
For something that
happened to them.
They happened to them and they want to, well, I think that's the beginning of a problem, and that's why they have a commission, a group, and the ethical committee is not only for clinical issues. They treat all these problems that you say, and they meet, and somebody has the suspicious, somebody have to come. There's a lot of steps. For example, in this case, if the problem is with the manager or the supervisor, now where they are cutting off the supervisor's level. They are now manager, and after the manager, the nursing chief, the officer, and after, of course, the VP, and after the CEO. So in this chain, if you have any suspicions, you just have to use the hotline compliance, and the ethical committee have to, with a multidisciplinary group, bring a solution for
So
that.
all of these things come before the ethical committee?
Yes, ethical committee, and yes, an ethical committee, because you're gonna see this multidisciplinary, and they treat all this. I have, you can take one copy of.
Yeah.
I will say when it's more personal, there's an employee who wants to do something against somebody or wants to plan with an employee. Yeah, I mean, I think there's more of course complicated, and the level has to be go to the vice president, you know, and to make interviews and investigation what's going on.
So predominantly they go before the ethics committee, and then what goes to the administration?
Yes,
What?
administration.
But what goes to administration?
The one that you mentioned, that kind of retaliation.
But how do they know that? That's my point. When somebody calls the hotline and tries to build a case against something, someone, some department,
Okay.
how do they know whether it goes to the ethics committee or it goes to administration?
Yeah, well, I will say they follow this, what we just said, and we're gonna mention when you have to call the ethical committee. Okay. I'm gonna show now,
Okay.
And we're going to be in that. So we're gonna differentiate which one goes to. That's right. Thank you. Okay, so let's go to the PowerPoint. So because you see this is Dr. Martinez's presentation. I took some, and I took one from Dr. Mary Jo too. Because as you see, is not only, we already saw all the ethical issues at the level of the government. We see so many agencies, regulations. These regulations affect the institution, and the institution create the ethical code of ethics and all the regulations for the physician-patient relationship. So it's a kind of a chain, no? I put your regulation, I say what you have to do, and the institution also have to create the regulations and code of ethics for the employees. So that's why I bring the list of Dr. Martinez. Actually, I put it, I mean, we have different kind of hospital, federal hospital, state, government, community, local, rural, critical access, for-profit and non-for-profit. Baptist, for example, is a non-profit. So they need to invest. Whatever the profit is, they have to invest in the community. So that's why you see so many urgent cares all around, and, you know, different kind of new services to the community. Trauma centers. Okay, we have urgent cares, skilled nursing facilities. I mean, all these institutions that deliver care, they have to have kind of code of ethics, or how to, they're gonna establish how it's gonna be the relationship with the physicians, patients, families, and stuff. Mercy Hospital, you know, it used to be Catholic, but they're still keeping some standards, some Catholic standards. Apparently for 5 years. The 5 years, I think, were last year. I mean, they can now change the values, and they can change how they're gonna lead the relationship with the patients. Mercy Hospital is a Catholic hospital. They do not perform abortions, or they don't use I don't know, you know the...
No abortions, no sterilizations, no contraception.
Exactly. No sterilization, no contraception. Okay?
That's amongst the, there are other things out there. But
Yes, exactly. So we don't know if they're going to change, no? Now with
so far.
So far, no.
Not so far.
Okay, with the new administration. We see the different cost and ratio, I mean, the payment options. Why? Because there are so many regulations about this. I mean, the hospital has to teach, educate, physician, billing department, all the stuff related to this. You know, we have a huge problem with fraud, not only to the biggest institutions like Medicare or Medicaid. We have problem inside, conflicts of interest, you know. I mean, I have a vendor, the vendor have a family inside Baptist, that's the one who's gonna make the business, you know, so I'm selling the food to the cafeteria, but my cousin is the one who is in the middle. I mean, all kind of conflicts of interest has to be watched, you know, because there could be so many fraud inside, just inside the institution, and even worse, when it's Medicare. You know how many people goes to jail just because. And I want to talk about this because that's part of my job, okay? When I put here CDI, you're going to see, okay, this is Medicare, just to remind you what Dr. Martinez talked about, reimbursement and billing. We use the DRG, Diagnosis Related Group. That's the payment, the different pathologies go inside a group. You know, you don't charge for each. It's just not. There are comorbidities that change that DRG. For example, the patient can with acute congestive heart failure, but the patient have a pneumonia. So acute congestive heart failure is going to be our PDX, the primary diagnosis in this patient. And the pneumonia is going to be a major comorbidity. That major comorbidity change the payment now. If the patient just can with acute congestive heart failure and have no comorbidities, it's just the heart failures, the payment is different. Once the patient have an acute kidney injury, for example, it's a comorbidity, acute kidney injury is going to change the payment for the acute congestive heart failure. It goes to a group, okay? And the major comorbidities is pneumonia, encephalopathy, I mean, big issues that the patient need more resources to resolve the problem in this patient. So we have to watch that not only the patient has the appropriate diagnosis, because what happened? The problem with the clinical documentation is that Medicare don't pay whatever is not written properly.
Proper diagnosis and documentation.
Exactly. Yes. For example, it's not the same to say that the patient can with congestive heart failure, that say that the patient can with acute systolic or diastolic congestive heart failure.
Sorry to interrupt. Patrick cannot get logged on. But
oh, okay. Hold on a second.
Huh?
Gloria
is there?
Yeah.
Ed and Gloria there. Look, Ed and Gloria are there. So check your connection, okay? So it must be in there. I'm sorry.
We would like that.
Ed and Gloria.
Okay, I was saying that. Okay, it's not the same to specify that the patient have acute congestive heart failure, systolic or diastolic. What means is we need to specify the type and the acuity. Because chronic congestive heart failure is a different situation. You don't have to use the same medication. You don't need to, I mean, there are so many resources that you're not going to use it. It's a history of congestive heart failure. But when the patient come in, I was some physicians, they'll just say congestive heart failure. So what is our job? Doctor, you're using intravenous diuretics, lasers. You ask for consultation with the cardiologist. You have a beta blocker. You have indicated this. So I think you're treating an acute congestive heart failure. And the ejection fraction is 70, 65. So we think it's diastolic, acute diastolic congestive heart failure. Can you please specify in the diagnosis, because that's going to change completely the payment from Medicare, from Medicaid, and from Medicare, and even for the private insurance. So this is a problem that we confront very often in a daily basis. You know, I know the physicians, sometimes they don't have time for the documentation, sometimes. So why a hospital need a clinical documentation improvement program? Why we have a CDI program? What? Because of this. It's a fraud, upcutting, duplicate, excessive service, unnecessary services is an ethical issue. It's a problem. It's a problem, a severe, very serious problem with the governments and regulations, okay? Medicare and Medicaid. You see here, healthcare fraud includes health insurance, drug fraud, and medical fraud. There are several different schemes used to defraud the healthcare system. So Medicare is watching all this fraud. They have lost a lot of money with this kind of stuff. So they practically request to the hospital to have the CDI programs as a compliance program. I mean, we need you to check well, what are you documenting, what are you billing for? Because if not, you're gonna get in a vicious. So I remember like 3 or 4 years ago, Baptist has to return about $23 million for, not because the patient did not receive the treatment, it's because it was not documented, the appropriate diagnosis and the appropriate treatment. So we also watch, for example, doctor, why you documented sepsis in this patient? There's no criteria for sepsis here. Can you please watch exactly what happened when? So we had a big problem, maybe you know, with the electronic chart. Copy and paste. This is terrible. Terrible. Los electronic charts, like the history of the patient, the records electronic, because they don't write. It's not handwriting anymore. So what happened? The system sometimes copy the same diagnosis, and it's not. So we need the physician to say, did you rule out this? Please say that this patient has not this pathology. This not, because the billing is going to be wrong, the billing, and we're going to get in trouble. Okay. So that's very important. This is from doctor, because what? Now we're going to patient-centered care, and I took this slide from you, because now we're going to another area of the ethical issues, and they have to be allowed with that. Respect patient values, preference, and expressive needs, coordination, integration of care, information, communication, and education, the physical comfort, emotional support, involvement of family and friends. Since about, I don't know how many years, I was as a house physician at Doctor Hospital. So we include as a code, I have my badge, all the codes that we have to know, and so we're keeping in our badge code help. Code help is, since we have the family now as part of the team, taking care of the patient, code help is when a family member is the one who take the phone inside the room and call for the patient is deteriorating or something happened with the patient. So, I mean, the family every day have more involvement in the treatment of the patient, the care of the patient, and it's a good thing. No? What is the huge problem here? The communication. Why? Because Dr. Mario said in his presentation, there are so many specialists, physicians treating the same patient. You have the cardiology, the pulmonology, the infectious disease doctor, the occupational therapy, the respiratory therapy. I mean, and it's supposed that the hospitalist, I mean, the primary care physician hospital is the one who have to coordinate all this communication between the team, to read the notes, what the cardiologist said, what the pulmonologist said, what happened here, and to have that that's our dream, and to have that in just one progress note to say, okay, the cardiology just said this, but sometimes that communication is not easy because it's too many people involved, and there are few things that are isolated. So our job is to read the whole note, all the notes, and we are the one that actually can put together. So that's why we can ask the hospitalist, oh, doctor, you know what? The pulmonologist wrote that the patient have a pulmonary edema. Can you please write the diagnosis on your progress note, on your next progress note? And we just not ask. We have to justify also. Then he put the pulmonary edema. We see the CT. We have the X-ray, and you treat it with this. So there have to be criteria and treatment for that. So that's when you say, okay, see, the patient has to use these resources for this pathology. So, and of course, we want to see in the cases that I brought about respect patient values, preference, and needs. That's part of the same presentation, respecting patient values, recognition of religious belief. Of course, pastoral care is essential, and the bioethics committees, which we're going to see now what it is. So let's start with ethics committees. Ethics committees involve individuals from diverse backgrounds who support healthcare institutions with three major functions: providing clinical ethics consultations, developing or revising policies pertaining to clinical ethics and hospital policies, advance directives, withholding or withdrawal life-sustaining treatments, informed consent, organ procurement, and facilitating education about topical issues in clinical ethics. I think we have all, remember when Father Shafi gave us the consent, no? And the declaration do not resuscitate orders and all this stuff. When you implement all this stuff, you have to educate all the personnel. I mean, the nurses and social workers, and everybody has to be in the same page with the values, with all the ethical issues that we want to cover. So I'm going to repeat this: providing clinical ethical consultations and developing policies pertaining to clinical ethical and of hospital policies, and education, which is very important. So who becomes a member of an ethics committee or program? Physicians, not only in the clinical, surgery and psychiatry. I mean, that's the idea. It could be the best. Nurses in the same three different areas: surgery, clinical, and psychiatry, medicine. Social workers, clerical, pastoral care. Community members can be part of this. Quality improvement manager. Individual responsible for the education program at the facility. A lawyer, if it's possible. At least one individual with advanced training in ethics. Some ethics committees allow guests. This includes health science students, philosophy, graduate students, physicians, trainees, facilitators, and patient representatives. And in other institutions, they also can include leaders such as fiscal, human resources, patient safety, quality improvement, and compliance and business integrity. I mean, it's a very multidisciplinary team. You need to repeat it, or that's okay, you have the presentation. Facilitators, physicians, philosophia, human resources, patient safety, quality improvement, compliance and business integrity.
What happened for example, in my case, in the chart, my chart, they put in some, I don't know in what part I told that I was smoking in my youth, like 20 years ago. And for some reason, when I wrote all my medical records, she's smoker, and doctor recommend to quit smoking.
No.
Yeah. So in that case, what can I do to change my medical record?
Yes.
Because now I am facing problems with Aflac.
Of course, at the insurance and everything.
Yes, Aflac. I have the insurance that pays if I go to the hospital, and
you call medical record, say that you need to make a change in your record. That is not because you're not a smoker right now, and you need that has to be fixed. And they found that, yes, the physician, somebody has to write a note that is not. Okay. I mean, they have to sign
so
that they made the correction.
So it's written in a stone that is impossible to change.
No.
That's the advantage.
Yeah.
Being able to look at your medical records.
Yes, exactly.
It's not true.
Yeah.
That you can document that it's not true.
Yeah.
Okay. Then it can be changed.
Yes, that can be changed. And you have to, because smoker is, it brings so many changes in your insurance, coverage and everything. Yeah. Okay, los goals of Ethics Committee: to promote the rights of the patients, to promote shared decision-making between patients. The person is now incapacitated with the surrogates and their clinicians, to promote fair policies and procedures that maximize the likelihood of achieving good. So that here comes the beneficence and benevolence. So it's easy, the different. Father Chaffee explained to me. Beneficence is do good. Benevolence is to the wish, the will, the necessity to do good. That's why both are together, because I put the example. If you make a raffle because you want to get money to send to Puerto Rico, both are included. You want to do it because it's something that you wish is in your inside, and you're doing something, you do good. But some people have the benevolence but cannot do the beneficence because have some barriers. People in jail, people incapacitated, people, they feel the need to do something good for somebody, as everybody. That's why we're an image of God. That's good things that's coming from our heart. But we are not probably do the beneficence. So we just stay in the benevolence. So, but this is actually the why we do medicine. What we is the need to do good for the other. And to enhance the ethical environment for healthcare professionals in healthcare institutions. So this is 4 goals of Ethics Committee. Okay, promote the rights, to share decisions, promote the fair policies and procedures, and to enhance the ethical environment of healthcare. So under what circumstances should I call the ethics consultant service? And you also have in the yellow thing, you can have it and you can keep it for in the future. You perceive that there is an ethical problem in the care of the patient. And the healthcare provider have not been able to establish a resolution that is agreed upon by the patient, surrogate, and the clinician caring for the patient. So this is the answer.
Can you just go back a bit?
Sure.
Sorry, please. Maybe even the healthcare providers have not been able to establish a resolution. Okay, go ahead. Sorry.
No, that's fine. 5 ethical issues in a healthcare environment. This is another Dr. Martinez slide. Consent, informed consent. If the hospital performs a surgery without the patient providing informed consent, that procedure could be considered an assault. If the patient is culpable to take the decisions. Balancing efficiency and quality of care to ensure everyone is providing with access to the most basic level of care. Cultivating and sustaining competent healthcare workforce. You know that we are short in some places more than others. Nurses. ICU, for example, is each patient have a nurse. I mean, it could be one nurse for 1 or 2 patients, no more than that. Floor, normal floor, you can have 1 nurse for 6 patients. But I know there are some institutions that have 1 nurse for 8 patients. That's a lot. That's too many patients. So the nurses now need to have a scanner when they're going to apply any treatment. In Baptist, for example, they have an electronic system that they can just check the time when she put the medicine in that specific patient. Yeah. Because they have a frame that they cannot go more than 15 minutes, this drug or whatever. So it's easy to check if the nurse is, doing the job, but it's so much stress for the nurses, let me tell you. And the documentation in the computer, they say they spend more time documenting.
Oh, they hardly spend any time with patients.
Oh, yes.
Hardly any time.
And
even when they had to handwrite everything?
Yeah.
They don't do bedside nursing.
No.
Medical records.
Yes. And we need bedside nurses, that's what the patient.
Well, that's why you need co-family. That's why you need family there all the time.
Yeah.
Because somebody has to be taking care of the patient.
Yes. Have to be watching. And few patients need sitters, 1 by 1. But that's not, few of them. You have to justify why the patient requires 1 person, a nurse or a PCT sitting there the whole day, just watching the patient. So no, it's very complicated, sad. It's sad. For them, it's frustrated. It's a frustration, I think.
Well, it's regulation.
Regulation.
And it's all legal.
Exactly.
It's also protecting the facility and everybody else. But the point is, everybody forgets that in all of this is the patient.
Exactly. We went out to the track. The patient is no more center.
The patient is just an object.
Exactly. It's not the center.
Nobody, as far as I'm concerned, nobody, I don't care who they are, should be in a hospital without somebody advocating for that patient from the family. And that drives the nurses crazy sometimes too, but
yeah.
No way. You have to have an advocate there all the time. And always asking, what's that for? What's that for? What are you giving this for?
Mm-hmm.
Don't just take it, or don't just do it. Why?
Yes.
Why?
Yeah.
Because sometimes you get the same thing twice. Well, I just got that.
Yeah.
Oh, I didn't know you got it.
Mm-hmm.
Yeah.
Or no, I'm not supposed to get that medicine. The doctor changed it.
That's right. So more regulations and more errors like that. It means that people are more trying to document it because of the regulation, the laws, and not really paying attention what the needs of the patient.
And what happens if the nurses have their own assistant?
No, there's no.
Why?
No, because there's more employees. You need more people there.
Okay.
And they're not going to pay for that.
Yeah, but if you need one nurse for 3 people,
Mm-hmm.
or 4 or 6, you hire somebody that assists the nurse. So if they fill the paperwork and you need,
but it's not
the nurse can see more people.
Yeah.
Of course.
No,
And
I understand.
more focus. So if the assistant is filling all the paperwork and tell the nurse, look, you need to go to the room number 7 because it's easier.
No, I understand, but there's not how. We have the clerk, the person on the front desk. She just order the test, or she change few things and help the nurses with some stuff. But the nurse has to document what she's doing. She cannot dictate it to anybody, because that's another person who can make a mistake. That's also another step that it can be.
As you said, if the nurse, every time that comes in your room, you are the patient, scan your tag. So the assist or the person that is watching over them knows at the same moment that she is in room number 7 dealing with this patient.
Yes.
So she is giving this specific drug. So she's scanning the drug and giving it to the, so it's so easy to track them. Well, it's my...
No, but I remember. No, of course, we are all, I mean, everybody wish the best system, the best way to do this. And now the nurses work 12-hour shift, which I don't know what you think. I think it's not.
It depends. It depends where you're working.
Oh, okay.
Some people 12-hour shifts are fine. Other places, no. It's really too much stress.
Too much.
Too many hours.
Too many hours, and you get tired. The other day I read alarm fatigue. I mean, the nurse, there is a point that he doesn't listen the alarm. I mean, he doesn't listen, sorry. I mean, he listens, but he's not responding to the alarm because he's tired. So many beep, beep during the whole day.
Exactly.
So this is a bad alarm, the patient is falling, and nobody.
Well, that's my point. That's why you need family. You need somebody to be there with the patient. Okay? And you need somebody to keep track of them. I've done this enough times with friends and family and so on. I would never leave anybody in a hospital.
Alone.
Never.
Exactly, yes.
Because I just realized, I mean, I'm fully aware of it, more so probably because of my own experience. But on top of that, there are little nuances that you see that the nurses or the care providers don't see, but which are significantly important.
And pediatric is fundamental because only the mom can tell you, he has fever. No, but the temperature, he had fever. Because who knows more the temperature of your baby than you that you holding the whole day, and you know perfectly when he's normal, when he's not. You know? No, he's crying for this. No, maybe no, we check. He's crying because of this. So we need the mother all the time, 24 hours, with the patient, telling the pediatricians what's going on, you know, because they know very well.
The other thing is that the role of intensivists, I'm going to take this in the side, I think is destructive.
The what?
The intensivists.
Oh.
They really they don't have the interest in the patient that the primary care doc has.
Yes.
That their own primary, not at all. And I've seen it enough times now that intensivist comes along one day, next intensivist changing everything.
Exactly.
No. You know, and it causes arguments between the patient and the intensivist, and then the intensivist and the consult.
Yeah.
And you know, it's crazy.
It's
I think
crazy.
the whole intensivist system is a disaster.
Yes.
An absolute disaster. And they really themselves, many of them just don't care. They're just there.
They're very biochemical things. They just measure stuff.
I mean, it boggles my mind. And I know if I were going to the hospital, I'd say, I don't want that intensivist anywhere near me. You know, I mean, one of my friends had to do that. I don't want intensivists. You know, my own doctors will write my orders. My own doctors will take care of it. I'll call them. Well, he's a physician talking to a physician.
I think it's too much. I mean, it's not necessary. You have a primary care hospital is taking care of why the intensivists have to take part in this, you know.
Well, even that. I mean, the primary care doc and the intensivist change. The primary care talk, I think, changes every 2 to 3 days,
Yeah.
depending upon you were any intensivist every day. And then you have
Yeah.
your own physician or physicians
Yeah.
involved, and everybody's countermanding everybody else. It's crazy unless you are able to keep track.
Exactly. Yeah, no, it's crazy. Yes.
It's crazy. It's the system has
Oh.
to change. And it's so expensive.
Exactly.
Oh, yeah.
That's the other thing.
That's all of this regulation
Yeah.
is what has, yes, some of it's been good, but the majority has done nothing more than shoot up the cost of care.
Mm-hmm. That's right.
You don't find this in other countries.
No, at all. I
It's
don't.
crazy. It's
No.
absolutely
I remember-
crazy.
It's easier in other places. I mean, well, you know, you travel all around the world. You know how it is.
I remember my dad spent hours to explain the patient how is the sinus. Hours. And you have a lot of people and
Waiting for you.
He needs to understand what he's going on.
Uh-huh. Yeah.
He is going to live when he understood everything, why I'm giving the medicine and why I'm giving.
That's the
That you
doctor's
have a
responsibility.
full room.
Yeah.
I don't care. They can wait.
Yeah.
Yes.
That's a doctor's
Integrative care.
responsibility.
That's why our Catholic. I hope you wrote this. It says what it's supposed to be, you know, the patient as a whole. The patient, I mean, I have patients when I was in my rural practice. Yes, I have a headache, but I never had this kind of headache. But something happened to me. Oh, really, what happened? So you start listening to the patient. No, because I have a problem at home. I mean, my daughter now is doing this.
You learn a lot.
Oh, that's
Let them talk.
That's why you have that. You think, yes, I'm very nervous. I mean, I'm so anxious now. This is my, okay. Only to tell you what happened at home. Is the patient start relaxing and feeling a little bit better. Of course, you take your blood pressure, you give the medication, and you stop. You did what you have to do. But it was a very, I mean, it's very helpful when you can listen to the patient. It's not only the blood pressure is high and I have tachycardia, you know, I'm going to have a headache. It's not that. Okay, balance efficiency, end of life issues, of course, and allocation of medication. And this is from Dr. Martinez too, the best practice. Ethical conflicts remain a prevalent problem in today's healthcare industry, but several best practices can help healthcare organizations solve those problems. Some of those best practices are supporting the code of ethics, offering an ongoing education, which is very important, creating an environment where healthcare professionals can speak up, providing ethics experts, adding ethics mentors to units, holding family conference, reaching out to professional associations, and offering employee counseling services, which we have about this, pretty much most of these things. I really, when I was reading this, creating an environment where healthcare professionals can speak out. My feeling is the physician every day has less, how can I say, less opportunities to speak out. I don't know. I think everybody's on top of them too.
Mm-hmm.
Don't you feel it?
Well, they tell you what to do.
Exactly.
I mean, nurses, I think I might have mentioned this when I was
Yes.
giving my lecture.
Yeah.
You know, here I am, I've dealt with monitoring since before they were born.
Exactly.
And they're telling the patient that I need to section them because of the heart rate. And of course, that's all the mother needs. That's all the family needs. And they're, why aren't you sectioning this? I said, I know, the nurse told you I should. She said, yeah. Okay, so let me explain to you exactly what's going on here.
Exactly.
There needs to be variability, why the heart rate is going down during the contraction. You notice this, it's still good down there. Then it's going to come up, and it's going to be perfectly fine. If it does this, then we can talk about it. But most of the time, we can even correct for that without having to do a cesarean section.
Exactly.
But they're pushing,
Yes.
pushing,
Yeah.
because they believe the nurse.
Exactly. The nurse is so important in the medical
And if that nurse doesn't like you, boy, she can make your life miserable.
And the thing is that
Boy,
I don't know
boy.
why is the culture that the nurse is not your friend. They become your enemy sometimes. And this is
Just wanna let you suck
something.
it out. It was one of the reasons I said, I can't deal with this. These people,
Yeah.
you know, they're fresh out of nursing school. Okay, they have a right to speak up, yes.
Yes, exactly.
But they should take you aside and say this in aside so then you can teach them why that's not correct.
Yeah.
Rather than open up a potential lawsuit.
Yeah.
Because if that baby is born, even though that baby look okay, and the baby develops cerebral palsy at 18 months, it's my fault. Because I have perception from that.
Exactly.
Cerebral palsy has nothing to do with that.
Exactly.
But family believes that.
That's right. That's why.
And the courts will support it. As soon as they see the child, oh, you pay.
Oh, yes, exactly. And with the liability and all the stuff. So that's why in my department, we don't know actually. We ask the physician what we think. But the last word, the physician has the last word in this. Because he's the one who's signing. You know, he's the one who's going to put the diagnosis and he's going to put justify. So we do not lead them to put any diagnosis. We just ask the question, we put the criteria, we put the treatment, and he has the last word if he want to document it or not. Because the responsible for that documentation is just the physician. So, okay. Okay, example the question about professionalism, a general question about patient privacy or confidentiality. Remember HIPAA, all these issues come to the ethic thing. A question about ethical practices in the workplace, human resources, resources allocation, or the business practices of the institution. So they cover some of these issues too. But of course, I think administrations take part on this when the issues is too complicated at this level. Privacy, confidentiality, I have seen in Baptist Doctor Hospital, the day after, you don't see one person, what happened, you know, people stand, no, she was fired, oh, he was fired. Why? HIPAA thing. That person cannot even come inside to the office to take her or his stuff. They put everything together and give it to her at the door of the hospital.
Oh my God. That's terrible.
It's terrible. If she or he wants to come in, has to come with the officers of the security stuff. Yeah.
It's really a terrible way to treat somebody.
Yes.
And it's not always, they're not always the guilty party.
That's right.
They're not always, you know, I mean, I had that happen with a research project that I took over from somebody else. And the university wanted me to fire everybody on the project. I said, huh?
What?
If I fire everybody on the project, I have no history. Okay, so they decided who had to be let go. And I said, okay, you decide, you fire them. Because I'm taking over this project after you've done all that work. Okay, I'm not gonna have that happen on my time.
Yes.
And most of those people didn't do a damn thing. They just did what they were told to do by the previous people.
Exactly.
And yet they were all escorted.
Exactly. Exactly.
I thought it was so cruel.
Yeah.
This lady had 35 years already with Baptist Hospital.
No.
And she was fired and she couldn't come even, yes, because of HIPAA thing. We never knew what happened. I don't know what happened after with the story, but privacy and confidentiality is a very big issue. Question about ethical practices, workplace, exactly, human resources and stuff. So, what happened with the conscience of a healthcare provider conscience? What happens if a physician reject to do, maybe you have any procedure that the institution can do, like abortion or sterilization, and the physician says refuses because his values, he believes. You know, this is a question that Father Schoffer went to address. During the Bush administration, there were a federal healthcare provider conscience protection statutes. How the pronunciation? Protect healthcare provider conscience right. They prohibit recipients of certain federal funds from discriminating against healthcare providers who refuse to participate in certain healthcare services on religious or moral grounds. Sadly, the law was removed during Obama administration, but now Trump is again, or the administration, I don't know, trying to start again with that. So.
It's the other way around, isn't it?
Huh?
It's the other way around, isn't it? Obama was the one that was enforcing the fact that we had to do a procedure that the hospital said could be done, but we could not opt out of the procedure because of religious and moral principles.
Yes, that's the one I'm coming for the church.
That.
And I have another one here. That is what you say, the church amendment. Mm-hmm. The conscious provision contained in this, collectively known as the church amendment, were enacted in 1970, to protect conscious right of individuals and entities that object to performing or assisting in the performance of abortion and sterilization procedures is doing so could be contrary to providers' religious belief or moral convictions. This provision also extends protection to personal decisions and prohibit any entity that receives a grant, contract, loan, or loan warranty under certain departments implementing a status from discriminating against any physician or other healthcare personnel in employment because the individual either performed or refused to perform an abortion, or doing so could be contrary to the individual's religious belief or moral convictions. What was the what happened? I didn't get any.
Obama was trying to put through the fact that physicians, regardless, had to do, and in the hospital, by the way, the hospitals also had to provide all total health. It was really related to reproductive health care, women's reproductive health care, which nobody really understands anyway.
Yeah.
And the physicians in the hospital would have to provide for abortion, sterilization, contraception, IUD placement, everything, even though it was against their religious principles. The Sisters of the Poor were the ones that brought the first case against them. And that's still floating around.
Okay.
I mean, the Supreme Court told the Obama administration to go back and relook at this issue and get it straightened out. And don't bring it back to us until it's straightened out. In other words, the Supreme Court's saying, no, this is crazy. I mean, if these sisters or this hospital works under this function or this doctor works this way, they're entitled to do this. For example, that big case that's going about the cake. The guy who refused to bake a cake. This is how stupid it is. Who refused to bake a cake for two men he knew very well, had provided services for them in other ways, but now they came and they wanted a cake for their wedding. Well, now, see, he objects to the wedding, so why should he provide the cake? That case is going to the Supreme Court.
Don't tell me.
It's
really?
Stupid. You should have the right to say no.
Exactly.
Now, you can take it the other way that they're going to take it is, and I can remember this very well. My mother used to rent rooms as a way of making some income.
Exactly.
And she only rented to women. The federal government came out and said you could not discriminate like that. You had to rent equally. So my mother had to stop renting rooms. Because she said, I have these, all these female children in my house.
Exactly.
Okay. I'm not about to have a man in this house.
Exactly.
Other than their father. Okay, that's it. So she had to stop. That's the first infringement on your rights. On the other hand, the good part of it was that for people of different racial backgrounds, they were not going to be discriminated against because you had to provide housing regardless of race. So that was the good. Okay?
Yes.
Definitely it was a good.
Yeah.
But every bad has a good and every good has a bad. And so there's no in-between.
That's right. That's right.
So here, they were saying that people like me would have to do an abortion, we would have to do contraception, we would have to do sterilizations. Now, I'll tell you that I facilitated those because the hospital provided them. I wouldn't do the sterilization. If I was scrubbed in a cesarean section, for example, and the patient was going to have their tubes tied, I stepped back from the table. And everybody knew, there was no doubt that I did not approve of this. When a patient had signed a request for sterilization, and I had somebody who would refuse to do the sterilization because it was their day in the OR, then I would shop around to find somebody who would cover that case for them, because the patient was entitled by the law to have that procedure, whether I agree with it or not.
I thought that was a good solution for that.
So I would go find somebody. Now, some people would argue that you shouldn't do that.
It makes sense.
But that to my mind was my obligation as a provider.
Yes.
I wasn't going to do the patient knew. I always tell the patient, I can't do the procedure. I refuse to do the procedure because of my religious beliefs.
Exactly.
Actually, I had 1 or 2 patients.
Oh, really?
Don't do it after that. But anyway, so you give me a while till I find somebody in my group who will cover this.
That makes sense.
That's here. I mean, this is crazy, and Obama is really forcing this.
Yes.
As though that case is at the Supreme Court. At the present time, okay.
Yes.
There's still the Sisters of the Poor case that's hanging out there. Okay.
Yeah.
And they did not want to have to provide contraceptive health care insurance. Same thing with the diocese, any employees of the Catholic diocese and so on. This is hanging in the air. Okay? As far as I'm concerned, if you get a job with the Catholic Church,
exactly,
you should know this.
Of course.
You're taking the job for.
Exactly.
I don't get it. Or are you pushing an issue? You have your own agenda.
Exactly.
To get
And
inside.
it's about getting rid of religious freedom.
Exactly. Yes.
It really is. It's about getting rid of religious freedom. And if we don't fight for it, I mean, that's what this country started on, was religious freedom. They left.
Right.
They left Europe to come here for religious freedom. Now, admittedly, they had their own issues too, but that's not the point. The point is our country was founded on religious freedom.
Yes, but
we're losing it, and it's up to us to fight it.
We're going the opposite way to the dignity also. No, thank you. So we're gonna leave this. We're gonna have a break round for 5 minutes, no more too much. So we're gonna start with the cases to discuss the cases. 15 minutes? Okay, perfect. Bueno, thank you.
Vamos a tachar el dulcito.
So everybody received the cases, so you can open it, and we're gonna read it.
Oh, I don't have my. Well, I have my computer.
There. Okay. So we have different cases. I'm gonna start with this one. I'm sorry I don't have it. This one was provided by the director of bioethical committed Baptist. So I'm going to read it, this one. They say family conflicts, patient care. That's the where they put the title of the case. You can see it?
Yeah.
And ethics consult requested by the attending physician. This is not the one that you have on the screen, okay? I'm going to read it from...
Oh, it's a different one. Okay.
Yes, this is a different one.
Okay, so this is a different case.
Exactly. So ethical...
Wait, sorry, it was family conflict, and what was the other?
Family conflict, patient care. The ethics consult was requested by the attending physician.
Okay.
Ethical concern. Due to the patient's end-stage pulmonary fibrosis, the attending physician felt that intubation was futile, and it would lead to increased pain and suffering. The patient had voiced his decision for no intubation to the attending physician. The patient's daughter, who was his healthcare surrogate, has removed hospice and wanted a full code. Relevant past medical history: pulmonary fibrosis, increased cholesterol, history of dementia, severe aortic stenosis, hypertension, insomnia, GERD, and hypothyroidism. Relevant social history: live in a hospice, ALF. Current medical history: this 87-year-old gentleman was admitted to the ED, emergency, from a hospice, ALF, with progressive shortness of breath and severe pulmonary fibrosis, and hospice was discontinued by the daughter.
And hospice was what?
Discontinued by the daughter.
Hospice was discontinued?
Discontinued. PICC line plays it. A PICC line is for the aligned to administer treatment intravenous, and oxygen therapy via non-rebreather. Capacity competency status. Patient documented as capacitated by psychiatrists.
He
Patient
was documented as,
capacitated and capable to take decisions.
Psych said he was capable.
Capable, by say capacitated by psychiatrists. Advanced directive, legal decision maker. Patient's daughter was listed as a healthcare surrogate, and his son was listed as a secondary health care surrogate. Level of care status, full code. Full code means CPR and everything that can be done to keep him alive. That's what means full code. Assessment, chart review, and case discuss with the attending physician and the ethics committee chair. The ethics committee chair then discuss the case with the attending physician, and it was agreed that the patient wishes should be honored, as he was deemed competent to make his own health decisions. Recommendations. Ethics also recommended that the patient's end-of-life level should not be a no CPR to, and that his current medical treatment be continued. Follow-up. The patient agreed to the non-CPR. His conditioning deteriorated over the next weeks, and he quietly died with family present. So, what is the huge question here? The ventilator intubation, it was a substitute or assisting the patient. That's the question. And I discussed this case with a father. Anytime that is going to be substituting, that's the good thing? Substituting, you just prolonging
the agony.
Exactly, the agony. If it's assistant, you prolong in life. So in this case, it's going to substitute, so that was a good decision the area committee.
Well, he was end-stage disease.
Exactly.
So first of all, he expressed his own feeling of what he wanted. His daughter was not wanting her dad to go. That's what it was all about. She didn't want to let go.
Exactly.
That's the way I look at it. She just did not want to let go. But he already made his decision. He had already been in hospice, which that was his decision.
Yeah.
But now that he's in the hospital and he's told the doctor this is what he wants, and she's contravening that. Yeah. All she's looking at is
it was
a situation that's going to prolong his life. But he's not going to get well. No. It's impossible. It wasn't. Well, nothing is impossible, but it's unlikely.
But from the physical point of view, he has a COPD, a pulmonary fibrosis. This is an end stage.
Pulmonary fibrosis means that all the little air cells, the little air pockets in the lung are gradually getting hard and fibrotic, and so they cannot
ventilation. There's not oxygen
or release CO2. They're not functional anymore. The blood supply is being severely compromised, and you're not going to be able to get enough oxygen to survive. Yeah. To intubate them, will give them oxygen because you're forcing it. Number one. Yeah. And number two, prolonging life, but no benefit in the end.
Yes.
Because then not only are you going to intubate them, you're also going to sedate them. So what kind of existence?
Exactly.
Really
intubate and ventilator for
whatever period. And then he'll die of pneumonia maybe or what. Yeah. But the point is that the proper and charitable thing is that he should have what he wants in this situation.
Ed, are you there?
Yep, sure am.
Would you like to read this case for me, please? Sorry, thank you. Mr. Perry.
Okay, let me pull my stuff aside so I can actually read it all.
Okay.
Let me reduce it.
Oh, please, yes. Exactly, because I cannot
read it.
There we go.
Okay.
Okay.
Mr. Perry, not his real name, was 83 years old and had several medical problems. He had spent the past several months in and out of the hospitals and rehab. Prior to that, he lived independently in a small Midwestern town. Widowed many years ago, he subsequently enjoyed the company of a lovely lady friend who lived down the street from the Perry home. He had 5 adult children and numerous grandchildren. Life should have been relatively good for his octogenarian, thank you. But, wow, life is not good, not anymore. My body is all worn out. I'm worn out. Don't want to do all this anymore, Doc. They say I can't go home and be safe, and I'm not going to a nursing home. No way. Just stop that little gadget that shocks me, and that the part that keeps my heart going. I want them stopped. Yes, the pacemaker too. A magnet will stop it, right? Just do it, please. Okay. Go down a little bit here.
Yeah. Oh.
I know it moves. Tired of fighting. Mr. Perry had a cardiac resynchronization therapy defibrillator CRTD implemented a few years ago. It included an electrical pacing component for heart rhythms on which the patient was 100% dependent.
That's important, 100% dependent. Mm-hmm.
Wow, okay. The defibrillator had shocked him more than once just before he came to the hospital ER with this request. That was the last straw for Mr. Perry. No more shocks for him. No nursing home or rehab, hospitalization, or medications, and no more mechanical pacing either. I'm tired of fighting. Deactivating an internal defibrillator is one thing. The patient's cardiologist did not need an ethics consultation for this decision. If he doesn't want to be shocked again, that's his decision. And if he went off again after he'd requested it stopped, that could be the kind of torture, he reasoned. Deactivation happened quickly after admissions from the emergency department. A do not attempt resuscitation order was placed in the chart. Wow. But the pacemaker also, he wanted it stopped. Ought we do so? Would that be ethically respectful for the patient's autonomy? Or would it be physician's technician-assisted suicide? If we stop the pacemaker, Mr. Perry, you will die within a few minutes. Yes, I know. I'm tired of fighting. Please. The ethics takeaway. There are at least 3 ethics takeaways from pondering the situation. Although most of the clinical ethicists and cardiologists will argue that stopping Mr. Perry's pacemaker is ethically and medically permissible, there is a significant minority opinion that it is not. Other thoughtful people will see this as troubling, too close to the gray line between suicidality and permissible refusal of life-sustaining treatment. One survey of the cardiologist indicated that 77.6%, and equals 787, had been involved in pacemaker deactivation. Only 34.4% reported being comfortable doing so. Anecdotally, a pacemaker manufacturer's technician told me that neither he nor any of a dozen of colleagues would agree with the participant in turning off or down the sub-therapeutic level, a pacemaker on which the patient was dependent. 2 bioethicist physicians debate the issue in a case review published at the article titled it is permissible to shut off this pacemaker. The one dissenting from the pacemaker deactivation, in this case, like Mr. Perry claims, that doing so would be an assisted suicide, which he claims is wrong. Would it? Is it? We do not all agree.
Oh, no. Oh. So.
Informed consent processes, both oral and written, or cardiovascular implantable electronic devices, CIEDs, ought to include discussions of deactivation and end-of-life decisions. Clinical colleagues and I published a review of consent forms and patient charts for 91 patients who had received an implanted cardioverter defibrillator. Cardioverter, okay. Only one of those records gave evidence of the end-of-life discussion, which could involve device deactivation. This passivity of information provided patients regarding deactivation ought to change. Third reflection, one might reasonably ask whether Mr. Perry chose rightly. Even if we were to conclude that it was right of his cardiologist to respect her patient's autonomous decision, it is possible that Mr. Perry himself acted wrongly. He had grandchildren, one of whom was to the room when Grandpa died. Ought he have been willing to accept the lesser independence to endure suffering a while longer? To rethink what matters for the acceptable quality of life, if only to spend more time with his grandchildren, where his values ordered rightly? One need not judge by simply raising the question. I am not yet a grandfather, nor did I physically or emotionally suffer very much right now. But I think that in Mr. Perry's situation, I would hope to value and choose differently.
Mm-hmm.
Letting go. A hospital's ethics consultation landed on the side of permissible and respect for the capacitated patient's autonomy. Subsequently, Mr. Perry had his wishes respected, and he died peacefully, surrounded by his family and family friend, who read scripture and offered prayer. A priest chaplain and a previously given last rites. His lady friend sat by his side, held his hand, stroked his arm, and said, "We've had a good years together, but you've suffered enough. I'll let you go." Mr. Perry's last words were, "Thank you."
Okay, it's long, but you see how many factors, how many things they even. Thank you, Ed. It was perfect. You see how many elements take place here. The physicians actually read articles and everything. I mean, it was a very well-studied case. I mean, they look for information. That's what the bioethical committee should do. And in this case, it's the same thing. I mean, the pacemaker and the defibrillator were substituting the heart. I mean, the heart was not working by itself. In this case, it was the same example of the previous one. They did the right decision, even, I mean, based on what we believe. What do you think, Dr. Matt? It's okay.
I think, go back to the beginning. They deactivating the shocker.
Yeah.
He didn't have a chance. It was the shocker that was bothering him. He did not have a chance to really deal with having that taken off first and giving him some time to determine, because the shocker is not a nice thing.
Oh.
And he in my mind,
What is a shock?
it gives you a shock to the heart, but it's an electric thing to get the heart to start back up again. It's like CPR using
I don't know.
defibrillator
It's
kind of
inside
thing.
you?
Huh?
So
Yeah,
it's inside the patient?
Yeah.
Oh.
The cases disappear.
That's okay. So the point is that the first thing, the decision to discontinue that part, that was fine.
Well, that happened.
The second thing is he really should have given him some time to deal with not having that phenomenon in his life and see how he could function. Okay. Because maybe he wouldn't have made the same decision as long as he didn't have to go through that shocking.
Oh,
Okay.
I see.
I think to discontinue the pacemaker, I couldn't do that. I would have to say no, because I don't think that's morally acceptable.
Well,
I mean, that pacemaker is not doing him any harm. It's not giving him any pain. It's simply keeping some kind of a heart rate going. It will not, if he develops a situation in which the coder would have come in, and it sounds like he would have, that would take care of itself.
So they say that he was dependent 100% of, you say that the defibrillator or the pacemaker?
I'm saying that the pacemaker,
when they say patient was 100% dependent.
Yeah. Right.
It included an electrical pacing component with heart rhythms on which the patient was 100% dependent. The defibrillator has shocked him more than once just before he came to the hospital.
Right. That's not a nice feeling. That's shocking. Whereas a regular pacemaker,
yes,
when you don't do that, okay, all that does is as the rhythm goes down, it doesn't shock you. It just, I don't exactly remember how does it work, but it can straighten out the rhythm a little bit.
So you think that he could be with just a pacemaker to see what happened?
I think he should have been given that opportunity.
And not to turn off.
And not discontinue the pacemaker. As you can see, there were a lot of people uncomfortable with it.
Yes.
Okay?
Yes.
That tells you something.
Yes.
Somebody is telling you those things.
Yes.
And even the people in the company.
Yeah.
It tells you something.
Yeah.
And I think it's true that those companies making pacemakers should have in that whole thing what it's all about, what it does, how it works, and all these things about end-of-life issues. Mm-hmm. But, you know, you can die and the pacemaker could still go, okay? Mm-hmm. But you're dead. Whether that heart, whether it has a beat now and then or not, you're dead.
That's right.
The pacemaker is not going to keep you alive. A regular pacemaker is not going to keep you alive.
Oh, okay.
So I have trouble myself with discontinuing the pacemaker. Because essentially it's assisted, in my mind,
it's assisted suicide. Yes.
And that's what he's begging for. It's actually what he's begging for.
Yes.
He was so tired. So he was not thinking.
Let's get rid of this part and let's see how you do.
Yes, I agree. Actually, I agree because when I read the case for the first time, that was my first feeling, my feeling too. But
so the point is, if the doctor is telling the the doctor is able to not start the defibrillation.
In that type of pacemaker, they can disconnect the part that gives them the slot. They can inactivate it. Okay, just as they can also inactivate the regular pacemaker. They can inactivate the whole thing. Okay. So I think just inactivating the shock part of it could have changed how he felt. Then he might have died 2 or 3 days later.
Exactly.
On his own.
Yeah,
you know,
exactly.
He died without interference, and he died with his family. You can still have your family and everybody else.
Yes, exactly.
You know?
Yeah.
But my feeling that was assisted suicide.
Yeah.
My personal feeling.
Mm-hmm. Well, yes, it's.
Go ahead to see what Father says.
Exactly, that's what I want to, and I want him to read this case. We discussed the one with the previous one, so we're gonna ask him about this case specifically. Okay, I'm gonna read this. This is a different thing. Fiona's 22-year-old daughter was killed in a car wreck. Fiona took custody of her 2 grandchildren and worked as a housekeeper in a private home while the children were in a school. Fiona had no health insurance. She earns too little to buy an individual plan and too much to qualify for Medicaid. When she started bleeding, she just kept buying napkins to absorb the blood.
We're assuming this is vaginal bleeding.
Exactly, yes. She continued to work until she collapsed on the job and was taken to an emergency room. Once there, she was diagnosed with uterine fibroids, a treatable condition, but in the ER, her bleeding stopped. She received a transfusion and was released. 3 months later, Fiona was back in the ER, again with uncontrolled bleeding. This time, while she was being stabilized, the bleeding became a mere trickling again, and she was transfused, giving the name of the OB-GYN physician to see and release. Fiona tried as much as possible to do what the ER provider suggested. She did not, however, make an appointment with the physician because she feared medical debt. The bill from her first ER visit, including the ambulance ride, exceeded 2 months' salary. Twice more, Fiona visited the ER, but her medical problem was not treated either time. So she was encouraged to get help. On the 5th ER visit, Fiona was admitted to the hospital, and even though she was not insured, the hospital consented to allow her to undergo an elective hysterectomy. Fiona has been billed for the surgery and is attempting to pay. She's depressed, however, because she knows she can never finish paying this bill given her current employment. Questions for discussion. Step into Fiona's shoes. What else will you do besides go to the ER 5 times?
Visit the doctor.
Many physicians and nurses in ER work 3 12-hour shifts a week. It could easily be the case that Fiona was seen by different staff members each time she can. But her medical record has a history of each visit. Role play the procedure that your ER will have used when Fiona comes to her 3rd visit. According to ENTALA regulation, no hospital is required to provide post-stabilization procedures. But does a moral obligation increase with each of her visits? Is Fiona's hysterectomy an elective procedure? Why? Why not? What difference does it make? I think Mary can tell us.
Chances are it's not elective. Chances are
It was an
because
emergency.
it depends upon where her fibroids are, blah, blah, blah. You're assuming that the bleeding is coming from the fibroids. Either she has to take medication, have an endometrial ablation, but chances are she's going to end up with a hysterectomy.
Yeah,
Exactly.
I have the same.
Are the procedures for that collection at your hospital regularly reviewed by your EDI committee? Why and why not? Are your hospital, will you advocate for Fiona? Who could help her contest the bill, especially if it represents the full amount that her hospitalization costs? The institution?
I think, let's go back to the beginning,
Uh-huh.
to the questions at the beginning. The very beginning, go back to the case.
To the case.
Because Fiona's responsible to some degree herself.
For the grandchildren, and that she lost her daughter.
Well, she's responsible for these children, okay? So
Yes.
she has this episode of bleeding,
Yeah.
okay? She goes to the emergency room,
Mm-hmm.
and I'm sure they did more than just give her a transfusion. I would hope. They did
Exactly.
more than just transfuse her and release her. There was probably, or should have been, some discussion with her at that time, what her condition was about, why she was bleeding from the fibroids, and what the treatment should be,
Mm-hmm.
and what alternative treatments that might be available to her. The transfusion is just, they were, generally speaking, with fibroids, once your pressure drops enough, the bleeding will stop.
Yeah.
Okay, and then it doesn't usually cause your death. Okay, okay. Now, so they gave her the transfusion, and so she was released. But I'm sure, I would assume that they told her what she had, why she was bleeding from the fibroids.
Yeah.
That she probably would need a hysterectomy. What her alternative treatment could be, like going on endometrial
Suppressor, whatever.
When,
suppressive therapy.
Mhm.
Because she doesn't tell us how old she is. So we're assuming that she's probably still menstruating and still functioning. So the bleed, that can be treated at least temporizing with progesterone.
But do you think why the fact that she has no
Well, she should.
health insurance?
Yeah, that's
She went
financial.
5 times to the hospital.
And she got a bill for each visit.
And she was a bill, exactly.
Right. So on the
So-
one hand, she can't afford health insurance.
Yeah.
Okay. But, you know, it is hard to get. There's no question about that. It's very hard to get. And so that's an option that a lot of people do. It's a very common alternative for healthcare.
But we didn't resolve the problem in the 3rd visit, for example. That's the ethical issues that we have to
That's an ethical issue we
That's-
have as a country.
Exactly.
If we have socialized medicine, no problem.
If she has 2 kids that she's taking care, she
Huh?
has Medicaid.
Yeah, well, exactly. But that could be one solution. Another solution, Baptist has
No, she
Depends on your
doesn't apply
facilities.
for a
Huh?
Medicaid.
It depends upon your facilities.
It
and
depends.
Care depends upon the state.
you see that she earned, read the beginning.
sorry.
No, but I know
Uh-huh.
if you have a small kids and the daughter is dead, she's the
Sole provider.
No,
the
what?
custodian. As
Ah.
you say, at UBS custodian, you have a Medicaid.
Okay.
So until your kids are 21 or something like that, you are supporting with that. So
But don't you think that's a issue that's very often people earn too much to
very
receive
common,
health
very
and too
common.
much for Medicaid?
I think excuse me, Miss
Yes.
Dr. Rosa. I think the issue of the ethic with Fiona is the health insurance, because we can see in the case that she was afraid. She was afraid to go to the hospital because of the bill. The first time that she went to ER, the bill covered 2 months of her salary. So therefore, she's not taking, okay, this is my health. So no matter, how much that I'm gonna owe, so I'm going back, So she's afraid to go because she doesn't have insurance and she doesn't have money. I think the Medicaid insurance is the issue of the ethical, because that person afraid to go to the hospital to get care because I'm gonna get charged and I don't have the money to pay.
Yes. That's what is not supposed to happen. That's what doctor said. Socialized medicine, you go anytime you have a problem and it's resolved. 5 times visiting the ER with the same problem, bleeding. And nobody took any decision before that. At the end, she finally got in debt. She has to pay the bill. She had the 2 grandchildren and her daughter, they probably provide for her. So we have a serious issue here, that we as a Catholic, as a Christian, we have to be aware, because probably we're going to be part of one of ethical committees.
The thing is, somebody like her can go to the billing office at the hospital.
and pay
I mean, she
$10
can't get blood out of a stone. Okay?
Exactly.
So she goes to the billing office in the hospital. She explains the situation,
Uh-huh.
and she pays $2 a month.
Oh,
Okay?
okay.
All they want is an attempt to pay the bill. Okay, if you make some attempt, most facilities will work with you.
That's right.
Okay,
Yes.
they just want to know that you're not just,
Okay.
like getting free medical care.
Yes, yes.
You know this, but she explains everything to
Yeah.
them. They, for example,
Yeah.
she's saying, if she is in a state where she can get Medicaid, they'll facilitate that for her. They'll get social service involved, and they'll facilitate. So there is help available.
Okay. So it's good to know that they can happen to anybody at church. A friend of you, anybody. Many people can be in this situation. So can we give a very good advice to anybody? Well, now we know.
There's
Look
ways
for
that
help. You go to the social work.
The thing is,
Find the.
for my community, how many people that are aware that this service, or maybe like Dr. Mary Jo said that, do the attempt and then they will find a way to help you out. How many people that know this information? Sometimes we lack of information, we lack of resources information, and we don't know.
Yeah.
So that's the part of the hospital, I think, when it's like they made the point, maybe she was seen by 5 different providers. Neither provider knowing that much, but she had a hospital record. Why they didn't ask her, why are you not getting something done?
Uh-huh.
That's an obligation that a healthcare provider
That's right.
should ask the patient.
To ask for the social worker, what you say. When you're in the ER and you are in this kind of situation, call the social worker. They have the information what you can do. They have the information if the hospital offer any help, monetary, help, you know.
That's somewhere in those ER visits. That's sad that it wasn't brought up somewhere in those ER visits, that she's not getting the health care she needs. Why?
Exactly.
How come you're not getting this done?
Exactly.
And she, you know.
Yeah.
I mean, she too may have a sense of pride and wouldn't let them know.
Mm-hmm.
And you can't deal with that. That's something you can't go against. But it would seem that would have been another thing that happened with seeing her. And then her employer. Has she kept all this quiet from her employer?
Oh, yes, that's the other thing.
Okay. Has she even sat down with her employer and said, listen, I know I'm working here and I have these children and I don't want to lose my job and I don't want to quit my job, but I have to explain what's happening in my life. Yeah. And maybe her employer could have helped her.
Mm-hmm. That's right.
You know, so there's a pride issue here too.
Exactly. She was afraid. She was ignorant. So that we need. It's very important, Glaria, and I think it could be a very nice education to bring to our community, church, to provide information about this issue.
Yes, it is.
To family and women's. Okay.
Let me just tell you one more thing to share with you guys. During my internship, I choose to do some, pass some information with my community, the migrant camp, the Emmaus Spanish community, my community, about the natural family planning. Guess what? I went to the Spanish community, my community, and asked them, how many of you that know about NFP? Not even a single hands up.
No. Wow.
Not even a single hands up, because they do not know about natural family planning.
See?
So I was surprised that, in the church, people that involved in the church, that part of the ministry, they do not aware that the church, this is what the teaching of the church is. Mm-hmm. And I think that, we as people that study the bioethic and all the archdioceses, they need to do something about it. Because I was discussed that with my husband when I'm doing that presentation. I said, you know what? We lack of information.
Yes.
Even me, I know it, but I didn't know it that much deeper.
Exactly.
What the teaching of the church is, what the church want us to do, what God want us to do. Yeah. I think that's something we need to maybe create a group or in the church, in the community, to let the message go out, because the teaching of the church is not out there.
I think this is the main reason of this master. Father Shafi want to prepare more people involved, practical Christians, Catholic, to spread all this information. We are the first apostles working in this. So we need to spread the information and educate.
Glaria.
Yes.
Come January, I met this nurse practitioner who's been doing NAPRO here in Miami. She and another nurse, and they were looking for a physician that they could get coverage. So I talked to them and said I would do it, but I have to wait till January, till all this stuff is over, so that I can take the course, the full course in NAPRO, to become certified.
Nice.
I would love that too.
And then I had this in my mind with you. Once that happens, or while it's happening, we could come up with a program together, and others who might be involved, even from this class, of trying to spread the word among our parishes. But we have to come up with, a pamphlet and what it's about and so on, because those can be left by the churches. The priest doesn't need to approve that. Okay, but it would be better if we got the priest to approve it. If a priest said no, then we just distribute it to the women's organizations in the parish and let them deal with it.
I think it's very important. That's it. I was talking to my husband about that. Because when I went and do that presentation, and I'm asking this question, not even a single hands. I said, wow.
I know. That's a great idea. That's why we have to
So that's
go.
a project that we could do.
It's a project. It's a nice project.
that we could do, you know, as a group,
Yes.
of anybody who's interested, because it really means getting it out to our own parishes.
Remember that in the case of Fiona, she was uninsured, but remember we have so many illegal immigrants.
That's another issue.
That
The
they,
illegals are afraid to go to
the illegals are afraid to go to the hospitals and go for look for health care, because you know there is the issue of the immigration. So we need to educate people, and I think that's a wonderful project if you can do it. And
We'll see.
I'm doing too in my church. I'm doing the radio. I'm doing in my group. I'm trying to spread as much as I can information about what the teaching of the church and all the resources that we have, that we need to learn, be educated, be prepared. Thank you, Gloria, for your comments and your worries. Everybody's concerned about that. So let's continue. I think I have another case, but I don't know. I prefer to go to the now Catholic teaching. Oh, this is an interesting case. Let's read it. Who wants to read it?
An African-American male patient, 42 years old, is admitted to a skilled nursing unit after surgery for head and neck cancer with lymph node involvement, which is metastatic disease, newly diagnosed. Extensive excision of the tumor had been done, and the patient had a newly placed tracheostomy and feeding tube. Oh, not so nice. Tracheostomy is a hole here, so he can breathe, because I guess of the surgery. He would not,
Yes.
They did enough in his face and mouth that they couldn't do it, and a feeding tube so he could eat. His
Yes.
history included years of living on the street and active drug abuse at the time of admission. The patient was very anxious on assessment, focused on his tracheostomy, pulling on the connections to make sure they're working, and complaining of pain on an 8 to 10 scale, 8 on an 8 to 10 scale. Oh no. Complaining of pain, 8 to 10, on a scale of 1 to 10. So his level of pain was high, with intensity focused in the area of his surgical wounds. Although he receives morphine on an as-needed basis, he waits as long as he can to ring the nurse. Can you put that back up again? See if he's still in the hospital.
Yeah.
Yes, he's still in the hospital.
Yeah.
And then because he, as long as he can, to ring the nurse, because he worries that asking for pain medication will label him with the statin. He also complains about not getting much sleep and thinking often of the poor choices that got him into trouble.
Oh, into trouble.
He has anxiously related to breathing through this tube like I am not getting enough air in, and ongoing pain, which gets less but never gone. He readily admits to risky behavior, which had alienated him from family and social support for some time, and is willing to discuss his years of drug and alcohol abuse. When the nurses and the attending physician describe the patient's condition, they explain that his anxiety is probably related to being a druggie, and that his pain is mostly drug singing. Bad.
Yes.
Very prejudicial in nature, as evidenced by his calling for more medication a few times a shift, and that he seems to watch the clock. They also note that this patient is a homeless street person who waited too long to seek help. He hasn't held a job for some time, has no visitors, probably using his illness to feed his addiction. How does the man's history, as recorded in the chart, affect every encounter he has with healthcare professionals? What do you think?
What is presupposed by his life on the street, by his How does this man's history as recorded?
I think there is ¿cómo se dice?
Very prejudiced.
Yes.
Prejudiced. They're all biased.
They
prejudiced
label him.
against
Yes.
He's labeled as a druggie.
They label as a druggie. They put a name and last name on him. And they think whatever he does, he has a tube here. He has a neck tumor was removed. He has a feeding tube. And they say that it's because the druggie is looking for.
He probably
need
needs
more. Exactly.
Because he's tolerant. Nonetheless,
exactly.
He still has pain, and you must take care of the man's pain.
Exactly.
Okay. That's vital. And if his pain is taken care of, his whole stress level may change, and then he won't be so picking at this all the time.
Yeah.
Okay, and he won't have that sensation that he can't breathe.
Exactly. And he's anxious and everything. He has no family. He's a person who is totally isolated. How is even his hesitation to ring the bell for more morphine interpreted on the basis of his past?
He knows how people are judging him.
Yes. So what other behaviors the nurse cite as evidence of his judgment? How does the patient explain his behavior? Is any consideration given to the possibility that what is past? If a nurse were to walk into this patient room without any knowledge of his past, how would his waiting to receive further medicine be interpreted? He's not having any company. He's anxious about his condition.
Well, the nurse walking in there doesn't have that history, so she would respond to his request. But on top of that, you know, if she's talking to him about anything family-wise, she's going to realize that he really is alone. Okay, and he needs a little bit more bedside nursing care, which she probably can't give him, but that's not the point. The point is that she's going to have a very different attitude.
Let's see. Suppose that this case was brought to you for an ethics consultation. Are concerns about the patient's pain relief being drug seeking morally relevant? I like this question.
It's relevant in the sense of his tolerance,
Exactly.
but it's not morally relevant.
But it's not morally relevant. Because he's been using drugs and pain medication. That's what she said. The tolerance to this patient, that's why probably the dosage is too low for him. And he's ringing the bell so many times during the day. Because nobody is going, you know, again, is not centering the patient needs.
Yeah, but it's unethical of the nurses put names. That he's drug dependent when he needed.
You can write it. I mean, it has to be part of the chart, but it's not the way. I mean,
no, but it's unethical for the nurses.
Uh-huh.
Oh, you are a drug addict. We are not going to provide.
No,
How
no.
they know?
No, that's really bad, really bad. They just have to, with that information, to think, oh, this patient need a little bit more painkiller.
Yep.
Or
Okay.
a combination.
Or a combination of them, so he won't be ringing the bell and that often. You know.
What happened at the end, if at the end of his treatment, and he's coming back to the streets and he's more drug dependent?
Well, he's not going to be more dependent. He's dependent, period. Okay?
Yeah.
He's got that dependency. I'm assuming from what they're saying.
Yeah.
But the other thing is, when it comes time for him to go home, is to properly place him.
Exactly.
Find a proper, don't send him back to the same environment if you can possibly do it.
Yeah.
Because once he's back in that environment with those same people, you know, they're going to be pushing the drugs on him.
Exactly.
If he goes back into it on his own, that's, you know, would you at least try to provide some way of putting him in a different environment, okay?
Yes.
To help him.
But he was homeless.
And get him involved in a drug treatment program.
The same with the alcoholic people, where they come with
He's
stomach cancer, esophagus. Huh?
He's a homeless?
He's homeless, yes. Are any of the following circumstances morally germane? It says that's the the patient homelessness, his joblessness, his apparently delivery, not rehabilitation, his absence of visitors.
It's all germane to what's going on in this man's life. He's aware, she said up there earlier on, he's aware of his drug use history in the past and how this is affecting him.
Yeah.
But it's all germane in the sense of what's going to happen to him from here on in.
Exactly.
Okay. And he's had this massive surgery. What follow-up is he going to have for the care of his tumor? And for the follow-up, you know, for the replacement. Sometimes they put a prosthesis in.
Oh, yes.
And then they can get rid of this and they can get rid of the tube.
Exactly.
You know, so all of those are issues, whether he'll even come back for all of that. You know, I mean, if we can get him into drug rehab, maybe
Yes.
he can get a job.
Mm-hmm.
Okay.
Yes.
But he has to be willing to participate and cooperate. And that's a tough one.
Yeah.
It's really tough because addicts have their own personality.
Yes.
It's very, very hard to break that.
Yes.
Okay. And the last thing in the world is to get them back in the same environment.
Yeah.
That's the worst thing in the world for them.
What if the sudden a family member came in and they made it more complicated? I don't know. Sometimes help, sometimes no.
But all of this is biasing the nursing staff.
Yeah. What bias do members?
And the doctors. Don't believe it. I shouldn't say just the nursing staff. Bias is everybody.
Yes.
Because everybody
Yeah.
down.
Exactly.
Never mind that there's still a child who looks down.
Yeah. And it's very often that you see that. What bias do members of the clinical staff bring to this case? Are the bias justified? How do such bias affect the goal of care and proper pain management for this patient? We discussed already. I mean, there are the words I don't know how to say. They put a label on that patient, and everybody like a domino thing. Everybody start doing the same. So until somebody, what happened? We need to do something. We need social work. We need psychologists. We need, as a clinician, patient advocate, member of the ethics committee. What policies or procedures do you recommend ensure that this patient and other will not receive unequal treatment because of this bias?
You have to have policies, absolutely.
Yes.
And you have to have procedures, what they need to do.
In this case, somebody exactly is part of the bioethics committee or ethical committee in the hospital. Remember that as a community member, we can be part of committee. Because then a policy has to be created for this kind of patient. We cannot judge. We cannot judge about this. The patient needs the right treatment for him in this moment, and he needs to be placed in another environment when he lives, and there's no complications. So that's it.
The other thing he needs is mental health assessment to make sure that his capacity is, in his mental capacity, he can cooperate.
Exactly. Okay, so now what we go is what the church says. No, here the two first chapters are specifically for the institution. Okay. Gloria and Ed. Remember that we have the book. Yes, you're gonna use it for the summary because actually what we want is everybody to be clear what actually Catholic institutions are. They have to, follow these directives, and that's what I would like to everybody to know by heart. So we have in the first part one, the social responsibility of Catholic healthcare services, and the second one is the pastoral and spiritual responsibility of healthcare. So you're going to read for the summary from 7 to page 14 and just select whatever direction you identify and write a little bit more about that or what you think about the directs. Anyway, we want to review some. No?
So you're saying run through pages
7 to 14.
And then give a summary.
Yes. Yeah. So we have, for example, Catholic healthcare ministry is rooted in a commitment to promote and defend human dignity. This is the foundation of his concern to respect the sacredness of every human life from the moment of conception until death. The first right of the human person, the right to life, entails a right to the means for the proper development of life, such as adequate health care. In Catholic institutions, particular attention should be given to the health care needs of the poor, the uninsured, and the underinsured. This is, you're going to find when you read it. Right. Catholic healthcare ministry seeks to contribute to the common good, which is very important.
Okay.
Within a pluralistic society, Catholic healthcare services will encounter requests for medical procedure contrary to the moral teachings of the Church. Catholic healthcare does not offend the rights of individual conscience by refusing to provide or permit medical procedures that are judged morally wrong by the teaching authority of the Church. We already talked about that. The directives, number one, a Catholic institutional health services is a community that provides health care to those in need for it. This service must be animated by the gospel of Jesus Christ and guided by the moral tradition of the Church. There's another one here that I didn't. In accord with his mission, Catholic healthcare should distinguish itself by service to and advocacy for those people whose social condition puts them at the margin of our society, like a Fiona, for example, that was in a and makes them particularly vulnerable to discrimination. The poor, the underinsurance, children and the unborn, single parents, the elderly, those with incurable diseases and chemical dependencies, racial minorities, immigrants and refugees, in particular the person with mental or physical disability, regardless of the cause of severity, must be treated as a unique person of incomparable worth, with the same right to life and to adequate health care as all other persons. This is the number three directive in the first part one, social responsibility. I think this explains everything that we have been talking here, okay? We have Fiona, we have the person with the drug addiction and uninsured. I mean, we have been speaking about all these cases in the whole class. I don't know if you read something about Charlie Gard.
Charlie Gard.
And the Cardinal Sgrezia.
I guess that's how you say it,
Sgrezia. He's one of the masters in bioethics inside the Catholic Church. Yes, if you want to know anything about bioethics in Catholic Church, please go and Google this Cardinal Sgrezia. He has written so many things about bioethics. I don't know if I wish we can have any email or something that we can even send him any question when we confront any ethical issues or bioethical situations. So he wrote 10 points. I just ran 4, but you can find the 10 points. I have it in Spanish here. They call 10 puntos, 10 points that bring down their arguments about the Charlie Gard sentencia. How do you say? Sentencing to die. So he's one of the experts in the bioethics. Actually, around the world, it says. So we recall that Charlie Gard was born on August 2016 and suffered from mitochondrial depletion syndrome, which was affected his brain. He received assistance to breathe, is hydrated and fed through a tube, but received no other care. And we mentioned here when I said curable people, curable diseases, chemical dependence. I mean, this is the case of Charlie Gard. He was born with a disease that is really rare and not cured for that.
So there's no cure. So there's no way that you said here that no other care, but receives no other care. Which care should he receive?
No, he received no other care in the hospital, just the hydration too, because there's no cure of the disease. I mean, there's no treatment for this disease.
Yeah, because that kind of prejudices you what you're thinking when I read that too. Receives no other care. What other care would he need? I mean, he has to be, of course, fed, held, and all the things that babies need, and his mom and dad were there all the time.
Yeah, but
if there's no cure for his disease, there's no way you're going to treat him other than to sustain him.
Exactly. No, so
my question.
no, I mean that's what they say is, but receive no other care than this. I mean than hydration and tube, because he can do anything else for them.
Okay.
But the point is, to add on to that, he still needs human contact. Okay, he still needs to be held, and as babies do. And diapers changed regularly. He needs to get regular nursing care, as well as the kind of care that his parents can give him. And if they're not giving it to him, which they were, as far as I understand, then somebody, the nurses are going to have to do it, or somebody else is going to have to hold his child. And, I mean, it's still a treatment.
And the one of the conflict was exactly that, because the United States, they are doing a research in this disease, and they want to have the opportunity to give it to him, and the parents were agree to bring him to United States. And remember, this case went to the human rights big offices and the court and everything, because I know and understand England have a different and different philosophy and delivery.
Is the boy that they killed it already?
No, he died.
He died.
He died.
He died on his own.
Yes. So that's why everybody got involved. But the 10 points for me is very interesting.
One of the things is that they wanted to discontinue the ventilator on him.
Exactly.
Yes. They wanted to discontinue the baby was on a ventilator.
Ventilator.
And they wanted to discontinue the ventilator because in Britain, because the child was declared incurable.
Exactly.
The parents heard about and raised $1.3 million to find somebody who could treat him. And there was a researcher in the US, who thought maybe he could do something. And a lot of time was wasted.
Yes.
Okay? But anyway.
By the time the court decided that, I mean, it was no time to do anything.
The British court didn't want
the British court, yeah. I mean, it was involved the hospital, the government, the court, the justice court, and the human resource, human rights,
and our own country.
And the whole country, yes.
Our own country, because Trump said, bring him here.
They gave a visa and resident green card to bring the baby here. Even United States government got involved about Charlie Gard. So we just mentioned here, give care even when one cannot cure.
That's right. Must be.
So it's excessive care?
No, on the contrary. When the person has no cure, you have to take more care about that person, because it's not going to be cured by suffering.
Okay.
I mean, care about taking everything. Huh?
If that is the case, we need to describe which care.
Okay. Giving care even when one cannot cure. The human face of medicine is manifested precisely in the clinical practice of taking care of the life, of the suffering and the sick. It's not just, disconnected, they have no cure. So let's disconnect it. Don't give food, don't give hydration, because anyway, he's not going to live. That's what he wants to say.
That's what they wanted to do.
On the contrary, it's like the case of the drug, the other case. Because he's homeless, because he's this, because he's that, so I'm not going to pay attention at his pain. I'm not going to take any solution. So nobody's going to raise a hand to say, listen, he's a human being. In this situation, this, and this, he's a human being, and you have to take care of him in an equal as everybody else. So in this case, have no cure. So compassion, love, have to be given even more. And family support.
I mean, the family, everything was fighting, everybody was
Exactly.
fighting the family.
Yeah. So this is beautiful because I say the face of medicine is manifested precisely in the clinical practice of taking care of the life of the suffering and the sick. Have no cure? Okay. God is gonna, decide when this person is gonna go.
Have
and
no cure, you don't give them something to inject them.
Exactly. Exactly. That's the other thing. Human dignity, we already talked about. I mean, from the we get the birth unto death. Our human dignity is the main thing. We are an image of God, and it will really is the prevalence, the most important thing when you're taking care of anybody. Whatever is his past, whatever is the actual condition, whatever any other difference. The parent's decision has to be respected too. In this case, everybody was taking decision about and
Away from the parents.
away from the parents.
And that's a two-edged sword too. I mean, you have to pay patients, the parents really need to be educated. When you say respect the parents' decision, you also got to realize there's another side of something like that. For example, let's suppose these parents were of a certain type of religion, and they had a sick child with, let's say, a bacterial infection. The child is septic, and they're of a religious persuasion that you don't take that child to the hospital. So what do they sign? There's a group that's like that. You don't take the child to the hospital. The child doesn't need antibiotics. The child will survive. Just the infection has to run its course. In the United States, that's against the law. That child needs care. The child is a minor, therefore the child should have care.
Exactly.
So in that situation, you're not respecting the parent's decision. The government interferes. Okay.
Yes.
So it's like there are times we don't seem to know how to deal with this. Okay.
Yes.
And it's a tough decision because you say, okay, respect their decision, but then why don't you respect the decision of this other situation? Okay.
Exactly.
So there are two sides to that. And the third thing, of course, is, if the parents seem to fully comprehend and fully understand the severity of the situation and still want to go ahead and try some kind of a research procedure, then they have that right to do that.
Exactly.
If they want to try that, or they see it as a way that maybe this child who's dying anyway can contribute to somebody else by attempting.
Exactly. They look in the good for the baby. I mean, the parents. The false paradigm of the quality of life. More disquieting yet is the lightness with which the paradigm of quality of life is accepted, namely, the cultural model that inclines to recognize the non-dignity of certain human existences, completely identified and confused with the pathology of which they are bearer or with the suffering with which they are
I do
accounted.
not understand that.
Yeah.
I don't understand that wording.
Oh.
The cultural model that inclines to recognize
Yes, let me
the
just
non-dignity of certain human existences. Completely identified and confused
a las que
with the
identifican y
pathology
confunden.
of which they are bearers,
Yeah.
or with the sufferings with which they are accompanied.
I mean,
The
the person is not the pathology that they have. You have to separate. A person is not the disease that the person has. The person is
The person.
exactly a human with human dignity. So you cannot tell, oh, this person has no quality of life because have this. I mean, the patient has a suffering, but it doesn't mean the patient has lost the dignity to respect his life as a human being. That's exactly what we want to see. I mean, we know how many people suffering, but they are in peace inside. They are offering the suffering to God. They are living a very, life in a very, with dignity, with love, with peace, with bring actually hope to others. I mean, it's the way we do with the other case. We cannot label people because the condition, physical condition they have, that probably make them to be in suffering, no in pain, in suffering, but it doesn't mean the quality of life of this person is based on that. I don't know. Mary, did you get it?
I'm sorry, say that again. I'm concentrating on the wording here.
On the wording, okay. I don't know if you can, because I mean, in Spanish it's so clear for me, but never the patient can be reduced to his pathology.
No, the patient has a disease, but he's not the disease.
Exactly. Exactly. The church see people, person, human being as a whole. So something is the pathology you have in this moment.
With an illness. He's not an illness that isn't a human.
Exactly.
With an illness.
Exactly.
Mm-hmm. Exactly. So that's why in any case, in any condition, we have to take care of the person because of his dignity and image of God. Independent. And no label. Oh, this person, you know, poor quality of life. Oh my goodness, how do you see? No, the concept of quality.
And we have to recognize whatever suffering you're having, take care of it, try to relieve whatever we can in that sense. You know, human involvement. What's the word I want to use? They have to feel the love of a person.
Exactly.
You have to be giving them, and they feel it. But you may not think so.
Yeah.
But you know how the way you touch somebody is different.
Yeah.
If you're annoyed,
yeah.
But if you're not, you're talking and you're being tender with them and so on. You know, it makes a difference.
Of course.
When you work in ER, sometimes you're gonna be patients that are very
sometimes
from jail or from people very dangerous, people very yes.
But that's the way it is.
And they came with a wound because they want you know have a, and you treat it. I mean, you in that moment actually probably you don't know. Sometimes the police bring them and they know and they tell you this is so and so. But it doesn't make you a distinction how you're going to treat it. You're not going to say, oh, so we're not going to do anything. Don't take it to the surgical room. No. I mean, probably that's another thing that we take into consideration. A person is a person, have a mother, has a father, and they come and they beg you for.
Every one of them is a child of God, and you have to see.
Exactly.
You have to try, regardless, to see.
Yeah.
Jesus in them. And I can say that.
Exactly.
Sitting here, but I can tell you there are many times.
I know. I know. Yeah. So, any question, Ed or Gloria or anything?
Not at this time, though.
Not now.
No. Well, thank you, and I think we are done for today. So, as I told you, the summary from page 7 to page 14. Of if you can to add something in the slides, that's okay.
Okay.
So, thank you. Have a great day.
Thanks.
Going to be page 7 to 14?
14, yes. Ethical and religious directives for Catholic healthcare service.
I saw that you sent two documents, the PowerPoint and the case.
Yeah, Father Schofield sent us both documents, Claudia.
November 19th.
I'm gonna stop recording, okay?
Okay.
Okay, bye. Thank you, bye.